review. We're going to cover weeks 7, 8, and 9. So pull up your study guides. Take good notes, okay? I'm going to share my screen. Don't worry about putting your names in the chat. I have all that when I get my report. Share my screen. So I have some tips for you of things I want you, things I want you to review. Can everybody see my screen? Okay,
Yes.
so week 7, infectious disease prevention and control. This is listed out as the concepts as we went through them in class. Okay, so reduce ways to reduce the spread of infectious diseases, including contact precautions. What's contact precautions?
We gotta use gloves, mask, especially N95.
Yep.
Yeah, packages.
What?
It's glove for contact.
Yeah. Yeah.
Okay.
What about caring for patients with TB? What's important?
N95
mask, N95.
What if they're in an acute care setting? Where do you want them?
In a private room.
Private room, negative pressure.
Okay. Okay. Let's talk about the epidemiological triangle. We review that in class. All right, agent, host, and environment. Remember, the agent is the virus, the bacteria, the chemical. It's something that's causing COVID, flu, chickenpox, whatever. It's the agent. Host is us. We're the ones who get infected. The live human being gets infected, right? And then the environment is wherever you are. What's your environment? Are you in a work setting? Are you in a hospital setting? Are you in the community? Are you at home? Where? What's your environment? And then how do all these three interact? So let's take an elderly person in a long-term care facility that gets influenza and they've had the vaccine. Maybe they're less likely to get severely ill, right? So you take your agent. How is the host? Are we healthy? Are we not healthy? Do we have, well, I'm just saying, are we healthy? Or are we not healthy? That makes a difference. Do we have comorbidities? Do we have other health issues that may cause us to be more susceptible to getting ill to whatever the infectious or communicable disease is? Do we have compromised immune status for some reason? Cancer, other diagnoses? That's gonna make a difference, and the environment's gonna make a difference. You know, what if we're a migrant and we're a migrant farm worker and we're living in crowded living conditions, and there's an outbreak of potential TB, right? So agent, host, and environment, that three have to come together because all three are going to depend. You know, what if it's a minor strand of the flu versus what if it's a chemical spill? So there's no right answer. There's just a lot of formulas you can break with. How does the agent affect the host, and how does the environment play into all of it? Right? What's active? There's two different kinds of immunity. There's passive and acquired, right? Passive, you're passing it on to someone else, right? You're passing it along. So maybe it's a mother passing on something to a baby. Passive, you're passing it on. Acquired, we acquire it through COVID. We acquire it through a vaccine, or we acquire it because we got it. We build our immunity. That's acquired immunity.
What a neighborhood.
Pardon me? Hello? What's the difference between epidemic and endemic? What does epidemic mean? Something's happened in excess of expected levels. Epidemic. The COVID was an epidemic. Okay. It was much higher than expected with the number of cases. But now COVID has moved into endemic. Endemic. Another endemic is the flu. It's always going to be around. So epidemic, excess cases of expected levels. And epidemic is also called outbreak. Okay? Endemic means it's not going away. It's always going to be around. We have a requirement that we have to report to the CDC certain diseases. You don't need to know a list of diseases. You just need to know their requirements. All right. So there are requirements for disease reporting in our country as mandated by state and federal law. Okay. The list of reportable diseases vary state to state. Okay, and these are all guidelines made by the CDC. So for example, when I was working in the schools, we had a book. It was from our local public health department. It was infectious and communicable diseases. Went through everything imaginable we'd see in the schools and whether it was reportable or not. So what I want you to know is that there is federal guidelines, state guidelines about reporting certain communicable diseases, infectious diseases. Okay? HIV, TB, STDs. I didn't add TB. And okay. So review the assessment, diagnosis, treatment for these STDs. Okay, so this was all in your reading. You can go back through it. Please review what I want you to review with each of them is what is it? And how do you diagnose it? And is there a treatment? Is there a vaccine? Okay. So that's from your readings. Which one of these has a vaccine to it?
No, hepatitis, I think.
So,
No, the tuberculosis.
herpes too, though.
What?
And
The hepatitis.
no, hepatitis have one.
Hepatitis. Hepatitis has a vaccine. The babies get it, right?
Yeah.
Let me get there. Is it bacterial or is it viral? Chlamydia is bacterial. Spread through sexual contact. I'm just giving you some quick notes. Bacterial, spread through sexual contact, treated with antibiotics. Right? All your sex partners in the last 60 days should be contacted and tested and treated. Chlamydia can be asymptomatic. It can cause pelvic inflammatory disease. That's why you had that quiz question about reporting any kind of, that was for gonorrhea, but reporting any kind of abdominal pain. Syphilis, right? It begins as a painless sore or canker. It moves through through your lymphatic system. It's kind of similar to flu-like symptoms. If it's not treated with antibiotics in the primary or secondary stages, it then can become latent and reactivate later on, causing severe damage, okay, to many areas of the body. All right. And at that point, it's no longer curable. In order to diagnose that syphilis has moved into the secondary stage, you need blood work to do that, a positive serology. We know that herpes simplex / genital herpes, viral and incurable. It starts as blisters around the genitals. We're talking about genital herpes, right? They ulcerate. These blisters ulcerate for several weeks, right? These virus moves into the nerves and it reactivates repeatedly, right? There's no cure, but we can treat with antivirals, right? And then we always have to screen for this because this could be passed to the infant at birth through the vaginal delivery, right? So with genital herpes, informing their partners of the disease to help prevent transmission. Right? There's a false narrative that the genital herpes is only transmittable when visible lesions are present. That's false, right? And with hepatitis, viral illness that attacks the liver, right? We know Hep A is fecal oral, Hep B is bloodborne, Hep C is also bloodborne. Who's at risk? Who's at risk for hepatitis?
and
IV drug users?
Yeah,
people,
work in the hospital.
resolve users, the immigrants.
Mhm. Patients in
Healthcare
correctional
workers.
facilities.
Care workers,
Yeah. Yeah.
nurses,
Yeah. Yeah.
childcare.
And remember that teaching from one of our quiz questions about the 3 months, right? We're talking about HIV now, right? Well, hey, let me back up. HIV, bloodborne, threat spread through sexual contact, sharing of needles. We need to remember about that 12-week rule that you can get a false positive for up to 12 weeks about being HIV positive, right? So you have to go back and check, redo that test in 3 months, right?
Yes.
Right? HIV infected people who live near one another, such as close living quarters, migrant housing, prisons. Right? Everybody has to be deemed non-infectious, so especially in the prisons, non-infectious before they can be admitted, because it can spread quickly. These people are immunocompromised. Right? And then TB. Talked a little bit about the mycobacterial disease that spreads through airborne droplets, right? And then we test through a skin test. We've all had, everybody should have, at this point, have had a TB skin test, right? What if it comes back positive? What's the next step? What if your skin test comes back positive?
What you ask them if they have a recent, one, and then they
Well,
do like another.
you move to a chest X-ray, right?
Yeah, the X-ray after that. Yeah.
Yeah, you do your X-ray, right? We know about N95s with TB patients. Okay, we know that we want them in private rooms. Okay, and they should stay in their private rooms, only come out when necessary. Okay. Bioterrorism and disaster. Review the two. What are the two types of disasters?
Natural and mankind.
Okay, give me an example of natural.
There's a hurricane, earthquake,
Okay, what about man-made?
fire, biohazard chemical
Okay.
stuff.
Let's say we're teaching families, we're in the preparation or preparedness stage in the disaster, and we as community nurses have been tasked with preparation. And so teaching strategies for families, what's included in a disaster kit? Stock enough food for 3 days. Reviewing the kit every 6 months for anything expired. Everybody needs to know where that kit is located. And everybody needs to know where to turn off the main utilities. That's how you prepare a kit. Another preparation teaching point is water. How do people know that water is safe to be drinking?
We gotta
Okay.
boil it,
What?
Bleach.
boil the water.
Okay. Specifically, boiling 3 to 5 minutes.
And then let the bleach sit.
Yep. The
And
bleach.
and 16 drops,
Yep.
16 drops of bleach, house
Yep.
bleach.
1 ml. Yep. Yep. Just letting it stand for 30 minutes, making sure you remove all the water from from the heaters and the commodes, if you have any commodes. Right? So when disaster happens, the nurse needs to recognize this is when the actual disaster happens. Everybody's in that impact stage. Everybody's at the same stage. They're dealing with the current disaster. All right. So what do you need to do? What's the priority? What are some priorities in that impact stage?
To
Giving
keeping
them
them
firm
safe
direction.
and firm direction.
What?
Instructions. Firm
keeping them
instructions,
safe.
directions.
Yeah. Instructions, directions. How about safety?
That's what I'm saying, to keep them safe.
Priorities to keep everybody safe. And whether it's
Don't
like
mess with
Cecily
them.
said, pardon me? Like Cecily said, It may be simple instructions. That's all part of your preparedness. But when the actual disaster hits, we have to ensure safety. Let's say somebody's exposed to a toxic chemical. How do we remove their clothes? And what do we use?
We use
Tongs.
gloves and use the tongs to
Yep.
to grab the
And remove
clothes
glasses.
and put in a plastic bag and tie them properly.
Exactly.
And if you have contact
Exactly.
lenses, you have to dispose take it throw them
Yep.
away too.
Okay. Yep, exactly. Some examples of, well, actually, I didn't put this in there, but a couple of agents I want you to we're just going to do this on the fly. Review anthrax. Review and there's 3 different agents I want. Anthrax, smallpox, and sarin. So, I want you to be familiar with these 3 and what they affect. What systems does if you had a potential anthrax exposure, what systems is this going to affect? This was in your readings.
Because more sores
Respiratory,
develops,
thermal.
Go ahead,
Cutaneous.
Cecily.
nausea,
Respiratory and skin. That's your anthrax. Okay, smallpox starts with flu-like symptoms that develops into a rash. Unfortunately, these rashes then turn into these deep pustules. They're like craters, right? So smallpox is skin. That's the main system it impacts. What's the difference between smallpox and chickenpox?
Smallpox is the under your feet and hands.
Yep. Palms of the hands, soles of the feet. Right? The other things to think about here, review, give examples of foodborne, waterborne, and vector-borne illnesses. Well, foodborne, right? That could be food poisoning, not preparing the food right at the right temperature, serving the food incorrectly. All right? Bad expired food, right? Waterborne illnesses. Let's say the stream or the river, the water's contaminated with whatever, fecal animal content. Somebody's dumped something in the water. Okay, and then you have your vector-borne illnesses, your Lyme disease, Rocky Mountain spotted fever, your Zika virus. Okay, malaria. Okay. Questions about week 7? Okay, let's go to week 8. Oh my goodness, where's my week 8 notes? Ah. Bear with me. There we go. See, I'm too organized to get everything hidden in different places. All right, home care. What's the difference between acute care and home care? Where are we providing the care?
the acute care in the hospital and the other one in a home or school. No, in a home.
Home care is
Sorry.
provided, simple. Home care is provided in the client's home,
Okay, that's home. Yeah.
right? And home care is specific to individual clients. It's not a big group big group that we care for. It's individualized in the client's home. Home care assessment. When we go in the home to do an assessment, we're just not, if they sent us to make sure the patient's pills are spread correctly amongst a week, okay, sure. But we go into do a home assessment, we can't just barge into the house and say, hi, I'm here to see if your pills are aligned for the next week. No, this is a relationship, right? If you're going to be their home health nurse, you need to establish a relationship, right? We need to get to know the client. We need to get to know the family. Who lives in the house? Who's going to be helping them with their meds? Who's going to make sure they take them? I'm just using the meds, for example. Who's going to make sure they're taking their meds? What does the house look like? Is it clean? Is it dirty? Are there safety risks? Are there environmental risks? So a nursing home assessment looks a whole lot different than doing an assessment of a client in an acute care setting. You get the whole environment to assess. Right? So it's going to take long, a whole lot longer than your assessment in a hospital in an acute care setting. There's so many things you need to observe. What else would you look at in your home care assessment?
For safety, if they had any rug in the middle, any hassle around,
Mhm.
and if they have their fire, I forgot the name.
Yeah. You have to do fall risk assessments, safety assessments, environmental assessments. Is there furniture all over the place? Are there people who live with them? Are they helpful? Are they not helpful? What's the dynamics of the environment? Okay, so it's a very in-depth assessment when you're doing a home care visit. And remember, you're entering into the client's home, you're their guest. You want to establish that relationship with them, especially if you're going to be going back. They need to like you and trust you, feel like you're competent. Why is it important to collaborate with multiple agencies when planning the transition? Let's say you're taking a client from the hospital setting to home care. What's the importance of talking and collaborating with others? And who might you be collaborating with?
Maybe physical therapy. They probably need equipment that they don't have at home that
Exactly.
can help with case management.
Exactly. Cecily's exactly right. Okay, there has to be collaboration. You know, there's a high likelihood that they're going to need resources. Cecily said it. Equipment, maybe PT, maybe OT, maybe cardiac rehab, maybe transportation, maybe food, maybe clothing. So you have to be collaborating, right? That acute care setting or long-term care setting that's sending the patient into the home setting, there has to be collaboration. What does this patient need to be successful at home? Because that's the goal in home care. You're trying to move the client back to as close to independence as possible, right? Importance of telehealth and how it relates to home care. A lot of clients are doing virtual visits now. The home care telehealth has really helped the home health care industry with not forcing patients to come in for every single appointment all the time. A lot of the times they're able to do these phone calls or virtual calls with their providers. What else? Review the steps and interventions when doing a safety and fall risk. What kinds of things are you going to look at? Well, if you, let's say you're doing a safety and fall risk assessment in somebody's home, what are you going to be looking for? Udelka said rugs, loose rugs they could trip on. I said furniture all over the place. What else? What if they're in a wheelchair?
Cord.
Cords? What about if they're in a wheelchair and they need help getting up? Maybe waistbands? Right? Whatever,
In the
whatever the
bathroom, the rails,
what?
the rails in the bathroom.
Rails in the bathroom? What about rails on the bed? Maybe alarms on the bed if they're gonna get up?
Lights.
What?
The lights,
Lights. Do they have appropriate lighting during the day? Do they have appropriate lighting during the night? Can they, if they can't get up to go to the walk to the bathroom, do they have a commode? Is it is it within reach? Do they know how to transfer from the bed to the commode? What's the difference between Medicare and Medicaid?
uh, Medicaid
Medicaid,
is for 65 years and up.
That's Medicare. It's 65 and up.
Medicare,
But
yes,
yeah, that's
Medicare
Medicare. But
Yeah.
the other
for
group
low
that's
income,
eligible, what?
for low income, right? The
Nope,
Medicaid.
that's Medicaid.
Yeah,
Medicare,
Medicaid.
hang on. Medicare is 65 and older, but it's also for anybody at any age with a disability,
Yeah, okay.
right?
disability.
Right? So it's above 65 and disability. Medicaid is the needs-based, right? Depending on your financial ability. That's needs-based. Okay, that's the big difference.
So Medicare for 65 and up, or somebody who has any
Right. Like
disability.
for example, my grandson, he's 2. He's already on Medicare. Unfortunately, he had a perinatal stroke.
Oh my God.
Yep. And then
Mhm.
had to have a hemispherectomy last year. And so he's permanently disabled. So he will be on Medicare and he's 2. So it's 65 or older or anybody with a disability. Well, let's go to community resources. Why is it important for us to be the center of the data bank of all the community resources? Why do we have to know that as community nurses? Most every
Okay.
client we're going to be working with is going to need some kind of resource. And if you're there working with them, they needed the resource of home health. But they're most likely to need other resources. Okay, we need to be resourceful and what community resources are available for all different kinds of clients, because every client we visit is going to probably have a different need for a resource. So in the schools, I used to have a binder of resources for parents, for kids, right? And as you meet community members and work in the community, you pick up all these resources. Public health departments are also a great resource. And this applies to the second bullet here. What do you do when you have non-English speaking population and you don't speak the language? And what resources might be available to them? Who do you reach out to?
For the community leader or
Yeah. Trusted community leaders that work with this population. Right? Remember, community nursing, you're not out there on an island by yourself. It's all teamwork. You're always collaborating and working with others in the community. And then case management, a few things about case management. Right? What is case management? Coordination of care. A case manager coordinates care. So that person leaving the acute care setting, going to the home that needs all the services Cecily said they need. Okay, that person is probably going to need to be case managed. Unless case management is usually reserved for the clients who have high needs, maybe multiple comorbidities, multiple things going on. Okay, let's say you have somebody that you're sending home that doesn't have a lot of family at home, doesn't have a lot of food resources, doesn't have a lot of financial resources, needs transportation issue, has transportation, can't get to their follow-up appointments. That's the kind of patient you want to case manage. But a patient who's going home with a broken leg and they're going to be out of work for a little bit, they have family that can take them to appointments, they can help them get around. That patient doesn't need to be case managed. It's reserved for the more complicated, resource intensive clients. Okay, case management, again, like home care, is individual based. We're not going to case manage a group of people. We're going to case manage individual clients. High cost chronic diseases. Lots of resources needed, lots of interventions needed. Okay, case management is labor intensive. It's a big job. It's time consuming. It's also costly. Okay, the caseloads of case managers are huge. And that's only the complex. More and more clients need to be case managed. Okay, and you see case managers everywhere. You see case managers in insurance companies, managing the more complex clients, case managers in the hospital setting, acute care settings, organizing or coordinating sending people home. You have case managers in the workplaces. You have case managers everywhere. Case management, yes, it's a big job. It's labor intensive, but it's very effective. Very effective in coordinating care. Okay. One of the problems with case management is fragmented services, right? You're having to get the PT in the house, get the OT in the house, get follow-up visits virtual or in person, medication refills, insurance companies. It's very fragmented. However, it requires a lot of coordination. So it is beneficial, but it can be fragmented. It can be case managers, really important part of the healthcare team. We talked about what clients would benefit. Communication. Okay, you need to know the difference between these 4 words: collaboration, assertiveness, cooperation, and compromise. Okay, you're going to be asked, you're going to be given a scenario, okay, of you and I are talking about this. What are we doing? Are we collaborating, being assertive? Are we cooperating or compromise? So let me just give you the quick definition. Collaborating. You're attempting to work with others towards solutions that satisfy both people. You're collaborating. Everybody's happy in the end. Cooperation. Cooperation is understanding, meeting the needs of others. You're cooperating. You're understanding what's going on. Compromising. Well, you find some kind of a mutually acceptable solution that maybe satisfies everybody. You're compromising. Okay, I'll give you this for this. All right, everybody's not happy in the end, but at least some of the needs have been met for each person. That's compromising. And then asserting yourself or being assertive is really presenting. I'm being assertive because I'm presenting my own needs. All right, I'm advocating for my client. This is what my client needs. Right? So I'm speaking about what they need. I don't want to collaborate. I don't want to compromise. I'm being assertive and telling you this is what my client needs. The other thing to remember about case management, and remember this about the nursing process, as you develop goals and plans of care, remember they can be fluid. Meaning just because the case manager comes up with a plan of care doesn't mean that can't change. Things change, scenarios change, maybe environments change, insurance companies change. So case managers have to be flexible. You have to be willing to take a step back and say, well, maybe the original goals we set forth in this plan are not appropriate now because they had another stroke. They had another fall. So now we're not planning them going home. Now we're planning them going to a rehab facility. Right? You got to be flexible. Okay. Care of the complex chronically ill. Review assessment, diagnosis, treatment of wounds and wound healing. This kind of post-op care. Okay. What do certain wounds look like? What would you do? Right? How do we prevent complications in post-op? Circulation. Do we wear the stockings? Pain management. What does the pain management plan look like? How do we manage nausea, constipation, UTIs from catheters? Delegation. Be careful when you delegate. Okay, when we're delegating, and that's whoever, RN to somebody else, LPN to somebody else, couple of things. If you're delegating, you better be giving specific instructions on what you want somebody to do. Not only that, you better show them how to do it first. Remember, they're operating under your license. What do you want them to report back to you with concerns or red flags? And how do you want them to chart or document? They are working under your license. If you go send them off to go change a wound and they say, I've never done that before, you say, oh, don't worry about it. Go do it. You're fine. Oh, what if something happens? So whatever task you're delegating, what's to be done? You need to show them. How do they do it? What do they need to report to you of any concerns? What do they need to chart? When we're caring for the complex, let's see, review discharge communication strategies with clients and families when they're assisting care of family members. What this means is we're working with the whole family unit as we're working to maybe send them home, that they're being discharged from somewhere. Long-term care, rehab, they're going home, or maybe they're going from home to the hospital or home to the rehab, wherever they're going, wherever their movement. We need to be able to communicate with the whole family unit. All right, we need to encourage the families, right? We need to encourage them to take turns caring for family members, right? Find help if you become too overwhelmed. Find support if you're finding yourself having a hard time taking care of the family member. Remember, home care is all about moving towards independence, or at least to the back as much as we can to where they were prior to them getting sick. We need to encourage independence. We need to support independence. They may not need somebody there with them 24/7. Okay, but we do want to include all the family members. Okay, because if a family's caring for at home with or not necessarily at home, but let's say the kids are caring from a distance, they come visit every day. We have to include that's part of our assessment. Who's going to be helping you at home, and how do we include them? Okay, so review the nursing process. This is all in your readings from your med-surg book. I'm not going to go through this, but please review how you take care of somebody with cirrhosis, COPD, diabetes, peripheral artery disease, chronic venous insufficiency, and hypertension. Okay. Week 9, for all of you that were just in my class, you have to listen to this repeat. What are some different types of violence? Give me some examples of some violence and abuse. What does it look like?
Violence, what?
Child abuse, child neglect, elder abuse, domestic abuse, family violence, intimate partner homicide, maybe violence in the form of murder, assault, battery, suicide. Lots of different kinds of violence and abuse. Mandatory reporting law. We all know we're mandated health reporters. We need to report any suspected cases of abuse or neglect. Doesn't matter where we are, work setting, home setting, neighborhood barbecue, grocery store, school. We have to report. Once we report, it's not up to us to follow up or to do any interventions. Our job is to report. That's what the federal state, federal agencies are there to do, to investigate. Not federal, but your local agencies, your Department of Family Services, your social services. Right? Review the most common factor related to intimate partner homicide. We reviewed this in class today. The most common factors are previous domestic violence situations. Okay. Prior to the homicide, maybe there was threats with guns, threats of strangulation, threats of taking the kids away. Lots of issues leading up to that intimate partner homicide. So there's been lots of other, it just doesn't happen overnight. Lots of history of domestic abuse. Why do you think what are the risk factors of people who abuse others? Substance abuse, alcoholism, lost your job, death, divorce,
Unemployment.
unemployment, people living in poverty, unexpected illness in the family, maybe unintended pregnancy. And typically, people who abuse others were often abused themselves. Right?
Mhm.
Risk factors for kids who are exposed to violence. Key observations when suspecting child abuse and or neglect. What's the difference between physical and emotional neglect? So what are the risk factors for kids? Go to my notes here from today. Kids who are exposed to violence. Kids who are exposed to violence, they may actually be the victims. They could also be witnesses, see violence in their homes, their parents, maybe a parent towards a sibling, a parent towards an elderly person living in their house, child against child.
Mhm.
Okay. Kids who are exposed to violence are at much higher risk for mental illnesses, self-harm, substance abuse, and actual suicide. We need to get these kids into some kind of a counseling or evaluation or working with the school. Okay. Physical. So there's two different kinds of neglect, physical and emotional. Physical, talked about this in class today. Okay. Physical refers to that there's actually a failure to provide food, basic food, to your basic necessities, food, clothing, shelter, hygiene, medical care. That's physical. Emotional. It's really the lack of or omission for nurturing, raising your children, not being in tune to growth and development and milestones. Not, let's say you have a kid that acts out, not being accepting of that or trying to help figure out the problem. It's emotional neglect, kind of checked out, right? Elder abuse. We've got physical abuse. It is what it is, right? Physical abuse of elderly. We've got emotional abuse, financial abuse, and neglect. Maybe emotional abuse. You're demeaning people, the elderly, demeaning them. It's affecting their self-esteem. Maybe you're calling them names, trying to scare them, embarrass them in front of themselves or their family, destroying property, maybe not letting them see family and friends. That's emotional abuse. Financial abuse. Let's say they're competent to handle their financial matters, but yet somebody else comes into the picture, maybe a child or a family member or a friend or a neighbor, and they take over the finances and start financially abusing. We as nurses have to be able to recognize those red flags. Elderly people are extremely vulnerable. We hear all the time about scams, phone calls and scams and scamming elderly out of their retirement savings or money. Okay. And then lastly, cultural influences. Okay. How do we build trust? We already went through this in a different concept. How do we build trust with non-English speaking clients? What are best practices for how to effectively communicate? Finding people in the community who are leaders of these different groups of non-English speaking clients. Finding who's working with them. What organizations are working with them to help provide them housing and resources. Those are the people you want to pull in. How do we best communicate with them? You know, maybe it's news bulletins in their primary language. Maybe it's fact sheets. Maybe it's pamphlets. Maybe it's videos in their language. But those community leaders that are already working with these populations are who you go to for help. They're your liaisons. How do we become culturally competent? How do we get there? How do we develop this? We had a long discussion in class today about that, and we talked about it in our Monday class. You guys tell me, how do we get there? How do we get to, what's the process of getting to be culturally competent?
The awareness to our cultures, and also to find a way to understand theirs.
Right?
But as a unique person too, like we had to understand generally, but also that specific belief.
Yep. Cecily, jump in. You were in class today. What else?
Research. Do your research.
Research on different cultures.
Yeah.
What about asking the clients and their
I was gonna
families?
say, also asking questions.
Ask questions.
Mm.
We need to see each culture, every individual is unique. Every culture has different needs. Okay, from language to food preferences to values to beliefs. Can somebody mute themselves that has all the background noise, please? Please. Cultures have a lot of similarities between cultures, but a lot of differences. We have to be mindful. We have to be knowledgeable. Different languages, different values, different beliefs, different practices, different preferences. All the way from food to healing modalities to how they look at end of life process, how they look at reproductive rights, who visits with them, who doesn't visit with them, and the restrictions, right? So culturally competent means being culturally knowledgeable about the culture. Well, first of all, we need to assess our own biases or beliefs, or we need to be able to understand our own culture is not superior to anybody else's. Everybody's unique. We also need to assess our own values and beliefs to make sure we don't have any biases or prejudices that would get in the way of us providing culturally competent care. We have to have that cultural desire to want to learn about different cultures. Because in this day and age, like I said in class today, you in your work life, personal life, kids' lives, whatever, you are going to be working, socializing with, meeting, talking, engaging with people of different cultures all the time. All the time. Okay. Culture, this last bullet, cultural awareness is exactly what I just said. Awareness of our own culture. All right. And how our own culture and our beliefs, are they going to impact how we take care of others? Hopefully not. But that awareness is what we need to deal with. And then cultural knowledge is knowledge about other cultures. Whether it's asking a peer that might be from the same culture, doing your own research, asking the client, asking family members, maybe attending community gatherings for that culture, however you gather that knowledge. But you need the knowledge to provide competent care. Right? So those are the important bullets that you need to know with regards to preparing for exam 3. Is that helpful?
Yes.
Yeah.
Okay. Anybody have any questions? I'll send out this recording later on, either tonight or in the morning. But but I appreciate you guys coming. Nobody has any questions that I can entertain? Hope you took good notes.
No, thank you.
You're welcome, Brandy. You're welcome.
Sorry I'm
Well-
late. Look,
Oh, that's okay. Just watch the part of recording that you missed.
okay.
Fantastic. Thanks you guys for coming. I really appreciate it.
Thank you for doing it.
Thank you.
Bye, have a good weekend.
All right, bye. Have a good weekend. See you later.
Bye-bye.